Good morning, salam sejahtera, salam Malaysia Madani. Thank you, Prof. Karin, for the kind introduction, and I want to also thank the organizing committee for giving me this opportunity to speak. I'm going to speak on a cancer which is the second most common in the country, colorectal cancer. And unfortunately, a large proportion of them, up to 70 to 75% of cancers that we see, are in stage 3 or 4. So we are working with the National Cancer Society of Malaysia in some way or another to see if we can change this curve to create a paradigm shift. Because it is a huge task trying to improve on the figures that we have. But try we must, because having worked with patients with colorectal cancer, I know that it causes untold misery and suffering for patients, not just for the patients, but also for families. Now, colorectal cancer, as I mentioned, going by the National Cancer Registry report, from 2012, 2016, as well as the second report, the cancer, it is a second most common cancer, which forms 14% of all cancers in the country. It is second only to breast. And going by this report from the World Health Organization, GloboScan 2020, it is the third most cancer worldwide after breast and lung, and is the second most common, is second most highest cause of death as related to cancer after lung cancer. Now, as I mentioned earlier, it is as we see from this figure from the National Cancer Registry again, up to 70 to 75% of the cancers that we have are in stage 3 and 4. Now, going to this report from MyScan, or Malaysian Study on Cancer Survival, which looked at all cancer which was collected from 1st of January 2007 up to 31st of December 2011. And it shows that the survival from cancer for colorectal cancer declines as regards to the stage of cancer that patients are in. For stage 1, the cancer survival is 74 plus, 5-year survival. As compared to stage 4, the 5-year survival is only 17%. Now, again, this paper from Netherlands, it is the same wherever we are. For stage 1, 94, and for stage 4 is 11%. So there's huge difference in terms of survival when it comes to the stage of the patient's disease. Now, this is one of the patients that I was involved in, a large cancer, and this is what we commonly see when we are dealing with cancers. Large cancers, by the time we are managing them, they involve other organs, they metastasize to other elsewhere, to liver, to the lung, etc. Nice to do, exciting to remove, but the reality is, the outcome for the patient and also for the families in related to this cancer is not good. Often, after a few years, they have recurrence, and we have to deal with the consequences of that. It's also, in terms of society, is also a problem, because often these patients are in their productive years of life. They're working, they're contributing to society, and at this stage, they are not able to contribute. So, in terms, how about cost? Figures from the Ministry of Health shows that for a stage 1 cancer, the cost that we need to treat them is $13,672 on average. And the cost of it mainly goes towards surgery. In comparison to stage 4 cancers, the cost rises to RM 27,972 on average. And this cost goes mainly towards oncological treatments. And if we talk about sustainable development goals, which Sunway University in particular is very focused on, target 3.4 says that by 2030, we want to reduce by 1/3 the premature mortality from NCDs through prevention and treatments. Now, if you compare with other countries, in Australia, the report from the National Cancer Control says that in 2011, their stage 3 and stage 4 was, stage 3 and stage 4 was only at 42% compared to ours at 75%. In UK, it was reported as about 55%, and in Canada, it's at 49%. So we have a lot of catching up to do. Now, if you look at the pathology of these cancers, the good thing that what we know is that it takes time for cancer to develop. From a normal colon to the time that it becomes a cancer, it takes about 8 to 10 years. So it goes from a polyp and it goes towards early cancer and subsequently towards a more advanced cancer. So now what we are doing, what we have and what we can offer is to do screening, whereby we try and pick up these cancers in the preclinical phase before they have formed a full-blown cancer. And screening enables the resection of precancerous polyps at early cancer diagnosis, both of which are associated with better survival rates. And we go back to the key message from the World Health Organization. The aim of early detection is to detect cancer when it's localized to the organ of origin and before it invades the surrounding tissues and distant organs, or for some sites to detect precancerous lesions. So what we have is the immunochemical fecal blood test, where what we are trying to do is to look at blood within the stool of patient, and subsequently we would go on to investigate them further to see if they have cancers or not. Now, this is an example of what we have of one of our patients that we dealt with. We have an early polyp, and this is probably malignant. We do not know if it's malignant. And what we do is we do a polypectomy, snap polypectomy, whereby the tumor is removed at the base. We use a heat device so that the bleeding is controlled, and we are checking for bleeding now. And subsequently, the polyp is sent to the lab for examination. What is the status of screening that we have in our country? It is available from the year 2014 to 2018. We have screened more than 127,000 people from the public, and out of that 11,000 plus were positive, which is 9.3%, and out of them they were all offered scopes, but only 55% turned up for the scopes, and 4.1% of those who were scoped were cancers, and about 13% were polyps. Right? So the detection rate is very low. So that's where the problem lies. So the screening that we have is opportunistic, which means the patients come for other issues. They come for diabetes or hypertension or anything else in our clinics, and they are offered opportunistically to do a screening IFOBT test. So, but we have a problem, as you can see in these data that we have, a significant number of patients do not want to go for the scope. And also, the detection rate is very low, which means we have to screen a large number of patients for us to pick up a small number of patients who have cancer. But it's still worth it, I believe, because if you can pick up even a small number of patients with colorectal cancer, we are transforming their lives by picking them up early. So we have to go based on data, and we know that based on data that our cancers peaks at about 50 to 60 years of age. We also know that there are ethnic differences, and in Malaysia, the Chinese ethnic group have got the highest rate, followed by the other races. And we also know that there's a difference in terms of family history. So our focus is based on these, those with high-risk groups. We also based on existing data on where our cancer patients are coming from in terms of the numbers as well as stages that they are presenting with. Now, we already have existing health clinics providing these screening procedures. And as you can see, from 2014 up to 2021, the numbers have grown up to threefold. But even then, even with this threefold increase, we are only screening less than 1% of the eligible population, which means all those people, all those in our population who are between the years of 50 and 75. Now, what does the data shows from our studies? And this paper from the Netherlands, which shows that by doing screening, we can reduce by 28 to 30 colorectal cancer-related deaths per 100,000 persons when starting from the age of 50 onwards. And if you look at other countries, Australia has done this very well, and they have a national bowel cancer screening program, and it is one of the flagship programs which is in Australia. And what they do is they send IFOBT kits to patients' homes, those eligible patients' homes, and it is sent back to the health clinics. And they also have public awareness campaigns, as well as their pathways on what to do if it's positive, what to do if cancers are picked up. And by this effort, they have managed to drastically change the stage of their cancers. Now, but our rate, what we have in our country, leaves a lot to be desired. And we have, there are reasons to explain them. One, there's geographic barriers. There is many places in our country, especially in East Malaysia, in Sabah and Sarawak, which are not accessible, and in terms of their transport, in terms of health facilities available. There are also economic factors here, whereby even though we provide IFOBT as well as scopes, there are other economic barriers in terms of patients who have come from out of work expenses and the transport as we have in East Malaysia. There's also problems in terms of healthcare infrastructure, lack of awareness among our healthcare workers, as well as lack of awareness among our patients too. And there's limited availability of screening centers in terms of IFOBT as well as colonoscopy centers. And lack of understanding in terms of unawareness of the importance of colorectal cancer screening and all that the screening program exists. There's cultural stigma too, as related to cancer and bowel procedures. We do not have a national cancer screening, a dedicated national cancer screening program, and our data that we collect has got room for improvement. So what can we do to improve on what we have? There are many different organizations who are doing this screening. Ministry of Health is being done in NGOs, is being done in National Cancer Society, but we need to come together. We need to engage all stakeholders and get together and come with a common goal. We need to have public awareness campaigns, media outreach, etc. We need to expand what we have. The IFOBT, not opportunistic, but we need to provide it as a national cancer program, and expand also the colonoscopy services. And this, what we have, it has to be integrated into our primary care, and it's important to audit whatever we are doing so that we see that it actually is giving the benefit that we are hoping for. Now, doing a scope and trying to diagnose cancer come with its own challenges. As you can see in these diagrams that you have here, sometimes the polyps is not as easy to diagnose. To an untrained eye, this can easily be missed. So doing a screening, because we often might be picking up early polyps, it needs further training. And the good thing is we have artificial intelligence technology which is coming into view, which helps us to identify the polyp or the cancer if it is suspicious and needs to be resected or not. Now again, another study was done in Minnesota, the colon cancer control study, which looked at 46,551 participants, 50 to 80 years of age, and they were randomly assigned to usual care or to annual or biannual screening with fecal occult blood testing. And it was found that the effects of screening with the IFOBT on colorectal cancer mortality persists after 30 years, and even though it does not influence all cause mortalities. Now, in doing this screening, we also have to be aware that it comes with its own risk. There are risks involved with doing colonoscopies. Even though it is low, we also need to be aware about them. Now, this report from the National Cancer Institute in UK, which raised some concerns about the possible complications which can occur. There could be physical harm, which from discomfort, from bleeding, from perforations, and there has been rare instances of even mortality, taking into consideration that these are normal patients. They are not patients who have got any disease. There could be false negative, where we could miss an early cancer, and especially like what I showed earlier, if it's early polyps, it gives a false sense of security. There could also be false positives, whereby even though the polyp is suspicious, it is not cancer, and unnecessary tests are being done. We could overdiagnose polyps that won't cause any problems, and it could also cause anxiety. And so there's still ongoing discussions and research regarding the optimal screening methods, the age intervals, and the period, and how often it should be done, as well, especially with the emergence of new technologies. Now, whatever we do, we need to audit our findings to make sure that the effort that we are putting in translates into results. So we need to audit, if we are doing a national-wide screening program, the percentage of early carcinomas, the interval cancers in between the scopes, the complication rate, the perforation rate, the hospital admission rates. All these need to be audited to make sure that we are on the correct path. Now, on top of the screening, we also need to work on other prevention strategies. And it is known that a substantial proportion of colorectal cancer is attributable to modifiable risk factors. This is a report from National Cancer Report 2021, and such as high body mass, low fat and vegetable intake, lack of physical activity, and tobacco use and alcohol use. So it is also found in this paper from 2017 that up to 18% of colorectal cancers in Malaysia can be prevented by appropriate preventive measures. And so finally, we have newer tests. We need to be up to date with what is developing in terms of newer tests. The FIT DNA, which combines the FIT test together with the DNA, looking at DNA in the stool samples, test for DNA, altered DNA. There's also liquid biopsies in colorectal cancers, which involves analyzing blood or other bodily fluids for tumor-derived materials such as circulating tumor cells. So the big question is that the Nobel Prize winning question is, can malignancy be prevented altogether? And I think that within the scientific community, the focus is more and more towards genetics. In terms of genetic markers, understanding individual predisposition to cancer, which can guide personalized prevention measures. Genetic testing, which looks at advances in genetic tests to allow for early detection of cancer-related mutations, and gene editing, which are being explored to correct genetic mutations that lead to cancers. And with that, I thank you.